Why cardiovascular disease appeared earlier than other mortality diseases. Number 1476, VPT Sharp 037, December 23, 2025. Gerald C. EclaireMD Foundation. Category: Metabolic Conditions and Mortality Diseases. Preface: After completing my very first medical research paper, that provides a grand overview of my 4 metabolic conditions and 9 mortality diseases over past 36 years, paper number 1475 titled A Unified Health Failure, From Multiple Metabolic Flows to Mortality Ruptures, a 36-year fluid VMT, solid VMT, and topological interpretation of disease progression, I raised another question in my mind. Question: Recently, I've been thinking about the following key pathophysiological question: why did I suffer 5 heart attacks from 1994 to 2004, yet have no cardiac events at all from 2005 to 2025? From a cardiovascular perspective, are heart attacks fundamentally different from other mortality-related diseases? Interpretation and answer: This is an interesting and deep question. From my learned cardiovascular perspective, there are indeed fundamental differences between heart attacks and other mortality diseases, especially when viewed through a fluid flow-based and solid structure-based viscoplastic energy lens, which aligns closely with how I now understand my own disease history over past 36 years. I will answer my own question in 3 layers. 1. What was special about from 1994 to 2004? 2. Why no more heart attacks after 2005? 3. How cardiovascular events differ fundamentally from other mortality diseases. 1. Why 5 heart attacks clustered between from 1994 to 2004? Heart attacks are acute rupture events, occurring in a system that has already been prepared for failure. Between from 1994 to 2004, several dangerous conditions overlapped simultaneously. First, metabolic preparation. Before 2005, my obesity, glucose dysregulation, and lipid imbalance were actively damaging my coronary arteries. This damage was slow, silent, and cumulative over many years. It built atherosclerotic plaques, greasy deposits stuck to the inside of arteries, endothelial dysfunction. The inner lining of blood vessels is no longer working properly, and microscopic fissures, hairline cracks, inside artery walls. Second, extreme external stress. The years from 1994 to 2004 coincided with intense corporate pressure, business competition, responsibility, time, urgency, and emotional stress associated with running a venture-funded high-tech semiconductor public company in Silicon Valley during from 1994 to 2002. This factor was the most critical reason. Stress does not merely raise blood pressure, it increases sympathetic tone, elevates heart rate, increases shear stress on vessel walls, and destabilizes existing plaques. In other words, our bodies have a built-in fight or flight system. When it stays switched on, our hearts work harder, our blood pressure remains high, and our blood vessels stay tense. What protects us in emergencies slowly damages us when it never turns off. Third, unstable plaque biology. In the early and middle stages of artery clogging, the buildup is soft and greasy. Because it is not hard yet, it is more likely to tear or burst. In contrast, during later stages, the artery buildup becomes hard and calcified. Although it narrows blood flow, it is less likely to tear or burst suddenly. Put simply, the period from 1994 to 2004 combined all the worst conditions. Vessel walls were damaged but not yet rigid. Plaques were vulnerable. Stress spikes were frequent. Strain rate changes were abrupt. This combination represents the perfect setup for repeated acute coronary ruptures. 2. Why no heart incidents after 2005? This is the key paradox that confuses many patients and even some cardiologists. The absence of heart attacks after 2005 does not mean that cardiovascular disease stopped. It means that the mode of failure changed. Several important transitions occurred. First, structural adaptation and scarring. After multiple heart attacks, my heart and blood vessels adapted. The most fragile buildups likely broke and healed. Some arteries became permanently narrow but less unstable. Gradually, stiff scar tissue replaced sudden, violent damage. Second, reduction in acute triggers. After selling my high-tech company and stepping away from the intense business pressure in 2002, my emotional stress and sudden physical strain reduced greatly. Although the underlying disease likely persisted, the acute triggers for rupture occurred much less often. Third, the places most likely to burst had already burst. I did not take any heart medications, so the heart attacks did not stop because of drug protection. Instead, my coronary arteries changed over time. They became more rigid, scarred, and permanently damaged, making sudden ruptures less likely. My vulnerable plaques were progressively exhausted, leaving behind stiffer and less rupture-sensitive vessels. Fourth, the problem shifted from sudden artery breakage to slow, long-term circulation damage that developed quietly over time. Instead of expressing my heart problems through multiple coronary complications or ruptures, cardiovascular damage continued quietly through chronic microvascular flow impairment, affecting other organs. In effect, my body shifted from sudden, violent breaks to slow, widespread damage that happened quietly over time. How cardiovascular events differ from other mortality diseases. This is the most important conceptual point. Heart attacks are not a disease in the same sense as chronic kidney disease, neuropathy, dementia, or cancer. A heart attack is a mechanical failure event. It is analogous to a bridge collapse. In contrast, most other mortality diseases are fluid flow degradation processes. They resemble river flow narrowing, riverbed sediment accumulation, and gradual loss of fluid circulation. Key differences. Cardiovascular rupture events are discrete, acute, threshold-based, highly trigger-sensitive, often clustered in time, and can stop abruptly when triggers change. Other mortality diseases such as CKD, neuropathy, retinopathy, dementia, and cancer are continuous, cumulative, time-dependent, energy accumulation, driven, often worsen even without symptoms, and rarely reverse spontaneously. This distinction explains my disease timeline precisely. My heart attacks were end-stage rupture signals during an unstable period. Once that instability phase passed, cardiovascular disease did not disappear. Instead, it expressed itself differently, later emerging as chronic kidney disease, neuropathy, retinopathy, progressive vascular stiffness, and eventually, stroke. In my own fluid-based VMT framework, cardiovascular and other disease events were harbors, and the metabolic river never stopped flowing. Is CVD different from stroke and others? Stroke sits between heart attacks and other chronic mortality diseases. It shares features with both, but it is not the same. Heart attack. A heart attack is a sudden failure in one heart artery. A weak spot breaks or gets blocked, often triggered by stress or pressure spikes. Heart attacks can cluster in time and may stop happening if triggers change or the weakest spots are already gone. Stroke. A stroke is a sudden event, but it is usually prepared by many years of slow damage to the brain's blood vessels. It reflects widespread blood flow circulation problems and blood vessel stiffening. Not just one weak spot, stroke often appears later in life. Other chronic diseases, CKD, neuropathy, dementia, cancer. These are not sudden events. They develop slowly over many years through silent, ongoing damage. Symptoms often appear late, after significant harm has already accumulated. One-sentence comparison. A heart attack is usually a sudden local failure. A stroke is a sudden end-stage event after long-term vessel damage. Other chronic diseases are slow processes without a single dramatic moment. Final summary in one long sentence. I suffered multiple heart attacks early because coronary disease expresses itself as acute rupture when plaques are unstable, and stress is extreme. But once the system stiffens, scars, and stabilizes, cardiovascular damage continues silently through chronic flow impairment, rather than through dramatic heart attacks. Analogy of fluid VMT, solid VMT, TDA, and a ship on a river with harbors, written for normal readers. In my fluid VMT view, my lifelong metabolic condition behaves like a river. This river is driven by obesity, glucose imbalance, lipid disorders, blood pressure, diet, exercise, hydration, sleep, and stress. It flows continuously through time. It never stops. Most of the damage is done quietly by the ongoing flow itself, not by sudden event of ruptures or failures. This continuous flow is a fluid dynamics-based VMT. It slowly wears down vessel walls, narrows channels, weakens circulation, and reduces the body's ability to adapt. Most of this happens without symptoms. Solid dynamics-based VMT appears only when the river hits something hard enough to break. These breaks are the visible events I call harbors, such as heart attacks, kidney disease, neuropathy, retinopathy, or stroke. Dementia and cancer also belong to this group. Even though I have not been diagnosed yet, a harbor is not the disease. It is simply where long-term damage finally becomes visible. The disease is the river flowing between harbors. Heart attacks appear earlier along this river because the coronary arteries are large, macro vessels, high-pressure vessels with fast blood flow, early in life. Plaque is soft and unstable, and stress surges create strong flow spikes. These conditions produce local weak spots. When the river surges, one weak spot breaks, then another. This is why heart attacks can cluster in time, and then stop once the weakest spots have already failed and healed. Stroke appears much later in life because the brain is different. It is not one large pipe, macro vessel, but a network of many small pipes, micro vessels. From a TDA topological perspective, the geometric shape and data point connectivity of this mathematical network slowly change over years or decades. Pathways narrow, backup routes disappear, and circulation becomes fragile everywhere, not just in one spot. Nothing dramatic happens at first. The river keeps flowing, but the biomedical network slowly loses its resilience. Eventually, after many years of quiet damage, the system can no longer adapt. One day a brain blood vessel, cerebral microvessel, breaks or blocks, and stroke occurs. Although stroke looks sudden, it is the final result of long-term, widespread circulation damage. This explains why I suffered 5 heart attacks between ages 47 and 57, and then my first stroke at age 78. So along the same metabolic river, heart attacks appear earlier. As local, trigger-sensitive failures at early harbors, stroke appears much later. As a downstream harbor, reached only after decades of silent flow damage and network collapse, my personal health and disease journey shows the same river, flowing past many different harbors at different distances downstream. Appendix: Macrovessel versus microvessel, a mathematical and physiological distinction. The key mathematical difference between macrovessels and microvessels is not anatomy, but which physical mechanism dominates flow behavior. Large blood vessels mainly carry pressure waves from the heart. Small blood vessels mainly control flow by resistance and branching. This single distinction determines how stress, strain, and energy accumulate. In each system, macrovessel regime, large arteries are long, compliant tubes. Blood flow in them is strongly influenced by pulsation from the heart. Pressure and flow propagate as waves, reflect at branch points, and interact with vessel stiffness. Mathematically, macrovessels are governed by distributed flow with compliance. What matters most is vessel stiffness and diameter, wave speed and pulse transmission, impedance mismatch and wave reflection. Pathology in this regime appears as increased stiffness, higher pulse pressure, and abnormal wave reflection, calcification, aging-related stiffening, and large artery disease primarily change how pressure waves move and amplify. In short, macrovessel damage is a wave and impedance problem. Microvessel regime: small vessels form dense branching networks embedded in tissue. Individual segments are short and narrow, pulsation is largely damped before reaching them. Mathematically, microvessels behave as a resistive network. What matters most is vessel radius sensitivity, network connectivity and density, local flow distribution and exchange. Because resistance rises sharply as radius narrows, even small structural changes produce large perfusion loss, occlusion. Blocked blood vessels, rarefaction, loss of small blood vessels, and endothelial dysfunction. Poor vessel lining function, primarily act by increasing resistance and breaking network continuity. In short, microvessel damage is a resistance and connectivity problem. Clean mathematical separator: the boundary between macro and micro vessels can be stated without anatomy. When wave propagation and vessel compliance dominate, the system is macrovessel. When resistance accumulation and network effects dominate, the system is microvessel. Macrovessels transmit energy as pulsatile waves, while microvessels dissipate energy through resistive loss. Disease interpretation: macrovessel disease increases pulsatile load and pressure amplitude. Microvessel disease reduces perfusion and tissue supply. This distinction explains why large artery stiffness raises stroke risk through pressure surges, while small vessel disease causes silent ischemia through cumulative flow loss. Relation to VMT and topology: in VMT terms, macrovessels accumulate damage through repeated high-amplitude stress cycles, leading to structural rupture. Microvessels accumulate damage through slow, distributed energy dissipation, leading to progressive flow failure. Topologically, macrovessel failure appears as discrete rupture events. Microvessel failure appears as gradual loss of connectivity. Disclaimer: this content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and related materials belong to the author, Gerald C.